Welcome to the HASTAM program, the Hand Surgery Talent and Mentorship program, which is mainly meant for the next generation of hand surgeons. This is the 13th episode of the first season of this program. In session 1, we have the first speaker, Dr. Jayakrishnan, who is a specialist orthopedic surgeon, hand and upper limb surgeon, and reconstructive microsurgeon at the Burjeel Hospital, Abu Dhabi, UAE. He has done his MS Ortho from Manipal University and also fellowship training from Wrightington Hospital, United Kingdom, and the National University Hospital, Singapore. He is a holder of the Diploma of European Board of Hand Surgery, the EBHS. He has been invited faculty member of International Hand Surgery Societies, and he is the author of more than 25 peer-reviewed publications. The moderator for this session is Dr. Anirban Chatterjee, who is a senior consultant hand and pediatric orthopedic surgeon at Manipal Hospitals, Kolkata. He has done his MBBS from Mumbai and then MS Ortho and DependB Ortho. He has specialized in pediatric orthopedics by working at Bhai Jirbai Wadia Hospital for Children, Mumbai, and fellowship in pediatric orthopedics from the National University Hospital, Singapore, and again a fellowship in hand and upper limb surgery from Wrightington Hospital, UK. He is a recognized teacher and guide for the National Board of Examinations for Orthopedics. He has presented papers at state and national level conferences and has been an invited faculty at various meetings. Dr. Jayakrishnan will be talking on management of phalangeal and metacarpal malunions, the role of corrective osteotomy. Over to Dr. Anirban.
Most of them heal well without any trouble with the standard treatment. So like Dr. Anirban told, the reason for malunion is probably an inadequate reduction, an unstable fixation, a delay in presentation, or a poor compliance, sometimes a fracture morphology itself. And unlike long bone fractures, even small deformities in the hand may produce a disproportionate large functional deficit when it comes to hand malunions. And why hand malunions are important? Because the hand performs a lot of intricate functions. So it's needed for coordinating the tendon gliding, balancing the intrinsic and extrinsic muscles, to maintain the normal joint congruity and for an accurate digital alignment. And a malunion causes a biomechanical problem, which is tendon imbalance, altered momentum, reduced grip strength and pinch strength, a digit overlap, abnormal joint loading, and accelerated cartilage degeneration, especially with intra-articular malunions. So in hand and especially in the hand, 5 to 10 degree, even a 5-10 degree of rotational malalignment can cause a 1 to 2 centimeter of overlap when it comes to the finger flexion, and making rotation the least tolerated deformity in the hand. So what are the functional consequences? In terms of rotational deformity, the effects are finger scissoring, inability to make a fist, impaired grip and dexterity, and unlike angular deformities, a rotational deformity cannot be compensated by the adjacent digits. And rotation is the deformity least tolerated, like I said. Coming to angular deformity, the effects are extensor lag, altered tendon mechanics, cosmetic problems, decreased power grip, and like we know, metacarpal malunions are more angular malunions are more tolerated than phalangeal angular malunions. And for shortening is the most tolerated one. So usually we don't have to commonly do an osteotomy for shortening, as it causes the least trouble for the surgeon and the patient. So it still causes shortening of intrinsic muscle or decreases the intrinsic muscle tension, and it also causes a decrease in the grip strength. Okay, and next is the intra-articular malunions, the metacarpal MCP and PIP malunions. It causes joint incongruity, abnormal pressure effects, stiffness, progressive arthritis, chronic pain, and these are the most challenging ones for the surgeons to deal with. Most of the times you are lucky if you are getting a nascent malunion and dealing with it, because if the patient comes many months later, most of them would have progressed to arthritis, and then the role of malunion osteotomy is limited. So why corrective osteotomy? Currently, corrective osteotomy is considered the gold standard treatment for a symptomatic malunion of phalanges and metacarpal. This is the same in wrist or other areas as well. So our objectives are to restore the anatomy, biomechanics, tendon balance, joint congruity, to get the digital cascade back and get the hand function back. So the benefits when we do the surgery are improved grip and pinch strength, the deformity is corrected, the range of movement is improved, pain relief, and a cosmetic improvement. And osteotomy and a normal fracture healing, the current literature says it is almost the same. The union rates are more than 95% in most of the series published in literature. So historically, there has been freehand osteotomy, which is still the most popular one. Different fluoroscopic planning techniques have been published. CT and 3D scans are used for analysis of a complex deformity. Studies are there on mirror image planning using contralateral hand and virtual osteotomy simulations, patient-specific cutting guides, 3D printing, and customized implants. And my experience is limited to freehand osteotomies, X-rays, and CT planning for these osteotomies. I never had to use a custom-made implant for the phalangeal and metacarpal malunions. So, however, these technologies have significantly improved our accuracy in terms of planning and execution. So, the normal radiographs are an AP, lateral, and oblique views. In certain situations, we go for CT and 3D CT reconstruction. Sometimes we take the opposite hand for comparison. Most of the time, extra-articular malunions and X-ray is enough. For some certain intra-articular malunions, we may take the help of CT scan. And the indications for surgery are rotation, shortening, angulation, deformities, functional disability. This is the priority. And now the indications are slightly changing. So when I shifted to UAE, patient comes with different demands. Not only what we thought that the only indication, there is extended indication also. So there should be always a tailored approach for each patient based on their problem and their request. So cosmetic deformity is also a concern. So the principles of correction are, if possible, always try to correct the cora or the deformity at its apex or the cora, right? So sometimes it is not possible. We may have to do an osteotomy at a different level and try to restore the length and means correct the rotation, preserve the soft tissue. Stable fixation and early mobilization is key. So without stable fixation, we cannot mobilize early, and it will significantly affect the outcome, post-op outcome in terms of stiffness and final result. So there are a lot of osteotomy options: closing wedge, opening wedge, transverse, derotation, oblique, step cuts, scarf osteotomy. So the most common ones are a closing and open wedge, transverse osteotomy, and oblique osteotomy, especially in intra-articular malunions. So what are the fixation choices? Mini plates, lag screws, and intramedullary screws. Out of this, my preference is, if possible, plates and lag screws, because that gives me the strongest fixation in terms of mobilization. Very rarely I use intramedullary screws in certain fracture or osteotomies where I think it is very stable and I can get away. K-wires and headless compression screws are being used, but I don't use it often because of the mobilization issue which I face. So let's come to some cases to understand it better. So Walland has transformed our practice recently. So if you have Walland anesthesia, and this will help us in a great way in knowing means during the surgery itself whether the osteotomy and rotation correction is enough or not. However, just a tenodesis test also will help. So we'll come to the rotational malunions first. For the phalangeal rotational malunions, we can either do an osteotomy in a metacarpal level or at the phalangeal level itself. So at the metacarpal level, it is very easy, technically easy, and cause less adhesions, whereas it little more technically demanding when it comes to the phalangeal because of the anatomy and the possibility of stiffness. However, the advantage is that if the patient already has a stiffness, a tenolysis can be performed easily during the surgery itself. So, phalangeal rotational osteotomy and metacarpal correction is ideal when the correction needed is less than 20 degree. If it is more than 20 degree, it is better to be corrected at the level of the injury or in the phalanx itself. And during the correction, we should always make sure that you are not twisting the finger while doing the rotational correction. You should always be correcting at the metacarpal itself. And after the shaft screws on either side, you have to check your correction. Always look for the cascade by using the tenodesis test, or if it is under Olan, to check with the patient before confirming and fixing. So this is a phalangeal malunion, rotational malunion corrected with the osteotomy plate at the metacarpal level. Here is another example, a young lady. She had a phalangeal fracture 1 year before, operated with multiple K-wires closed reduction. She has a significant malrotation when she presented. This is 1 year from the initial surgery. And we did a osteotomy at the phalanx itself using the osteotomy plate. I always go in phalanx with the dorsal approach, and this is the intraop checking using the tenodesis test. And this is the post-op X-ray showing good healing, and the final result with a acceptable deformity correction and range of movement. The key is early mobilization. Splinting and delay in mobilization can again cause scarring and affect our range of movement. Here is another technique for the phalangeal osteotomy described by Yoshihiro Abe. Here we can do the osteotomy, pass the K-wire antegrade through the osteotomy site into the proximal phalanx head, and then pass it retrograde again through the osteotomy. Flex the fingers like the jazz maneuver, and the fingers get automatically reduced into the decide position, and then pass the K-wire through the metacarpal head and transfix it, and then complete the fixation. In the study, they had used a hologram plate. So we also tried this technique using the same plate, and this patient was a little tricky, that this stiffness and deformity was there for many years, and she had some tendon problems also, and she never had a full range of movement, had angulation and rotation. So I tried to correct mainly the rotation and angulation, and this is the same technique. We use a similar hologram plate, and this is the result at 3 months. Then the patient was lost to follow-up. However, she was doing well, and the osteotomy anyway united. When we do the osteotomy, what we need to know is, if you do a osteotomy in the shaft level, it takes a little bit more time to heal. So if preferable, always do the osteotomy more close to the metaphyseal level, so the healing is within 3 to 4 weeks, it already starts healing, and we don't have to worry about a non-union problem later. And this is a case where I've done a osteotomy for angular correction, and this patient also is a 48-year-old gentleman. This malunion also happened a long time back. It looks acceptable to us because his function was okay, but this guy had a different request. He was doing another desk job and recently picked up golf as a sports, and that is the only thing which he enjoys now. And this malunion is affecting his grip. He tried for 1 year of conservative management, tried his grip, different techniques were used, and he was getting pain after starting the play. So after telling him and discussing about the complications and what is going into, so we finally decided to do an osteotomy, a closed wedge osteotomy. I had taken out a 3 mm wedge, and the closed osteotomy was performed. And this was the post-op pictures, and it went on to heal well. and he got a good result and he started playing sports. So even with, we know that fifth metacarpal is quite forgiving, even a bigger deformity is acceptable. However, sometimes the patient's demand is totally different and it is should be tailored to what is going on in his life and routine activities. So here is a combined deformity. This patient came after 4 months from a bad intra-articular fracture of the base of the thumb, proximal phalanx, and had rotational angulation and shortening deformities. So as you know, his thumb, you can see from the X-ray, the thumb was subluxed. He had a significant problem in movements of the IP joint because of the shortening. There was a significant extensor lag and pain. So I did an osteotomy. I had to correct the length. I'd use a olecranon graft in this case, and it was already healed. The intra-articular part was already healed, so I neglected it. I just maintained the angulation and length. And this is the final post-op. Went on to heal well and had excellent result. However, he still had a 25 to 30 degree of extensor lag at the IP joint. So this is another case of intra-articular deformity. So if you are lucky, you get intra-articular malunions quite early, maybe 1 month, 6 weeks. It's easier to correct. This is a young lady who was studying in Canada. She went to the emergency, did the X-ray, identified fracture. But by the time she got an appointment with the consultant, it was already 1.5 months and the fracture healed. Then she traveled back to her country here and I saw her. It was already fully united. But this is where the oblique osteotomies come. We go dorsal approach. We try to find any gap possible either at the metaphyseal level or in the joint where we can slowly mobilize the articular surface and lift it up and fix it. So I usually use only a blade for this, or a 50 number blade. Doesn't use any osteotomes because these fragments can be sometimes very fragile and maybe smaller than what you think. So got a decent lifting up. There was a little bit of bone loss in the metaphyseal part, but went on to heal well with a 10-degree FFD at the PIP joint. This is another case where the patient came little early, 1 month post-op, still healed. Patient had an acute renal failure, so could not do surgery at that time. And this is a similar surgery, an oblique osteotomy and lifting and fixing with intrafragmentary screws. Intrafragmentary screws are one of the strongest fixations and we don't have to augment with a plate and you can start straight away mobilization on all of these cases. So this is my last case for the day. So this is slightly more tricky. I saw this patient 4 years back. He had a middle phalanx comminuted fracture. I discussed treatment options with him. He chose no surgery and disappeared. Comes back after 4 years with a finger slightly angulated and the x-ray like this. So I discouraged him, told him to leave it as it is, as it looked okay, cosmetic deformity only. But the patient kept coming back telling that he cannot look at his fingers. In the last 4 years, every time he look at his hand in the morning, he thinks about it and he has to move forward in life only if he corrects the deformity. So then we decided again to solve the issue, did some planning. You know that on the radial side, there was a shortening by 3 millimeters. So we opened on the radial side, found the apex of the deformity. In this case, we went with an open wedge osteotomy. I took out a 2 to 3 millimeter wedge, temporarily fixed it with a K wire, took a wedge from the olecranon in the same size and placed it back again and put the same K wire back and fixed it with the K wire. This is the result at 3 months follow-up. It has healed well and the length and angulation has been corrected fully. And this is the final result. Finger looks straight now. So what are the latest advances? There are papers on minimally invasive corrective osteotomies. This paper from China discussed about a 3 millimeter incision percutaneous K-wire frame, and they had a good series, 31 patients in their series, and had good correction achieved. So this is what I think may come up in future. This is like we all know, this is the MIS surgery for a hallux valgus correction. The incision, if you see, it is just maybe few millimeters incision. It is a lengthier procedure because of the jig used, and they use all kind of severe deformity corrections and translation, which are scarier to see in the X-ray, and they start weight bearing also, and but patients are okay. So this is a jig used for that. So I hope that in future jigs like legs can be, I mean, it will come up in hand surgery also for our deformity corrections. And this paper discussed about corrective osteotomies using CT based and custom made jigs. So never had to use one, and I don't think it is needed for a simple extra-articular malunions in the phalanx and metacarpals. And probably in future AI role may come. Future applications may include maybe automated planning. They will give us all details. Deformity measurements can be done, navigation and robotics. I'll give an example. This is one of the studies we did last year where I was involved. It was on knee, where we did the machine learning, developed an AI app, and after that, whatever x-rays you put in the system, it will automatically give all the angles around the knee, and also will tell you the Kellgren-Lawrence grading for the knee osteoarthritis. Similarly, we are working on one in the shoulder, and probably similar apps for the hand and wrist are also available sooner. So what are the taking points? Rotational malunion is a major functional disability, and we need individualized correction and correct the deformity at the apex whenever possible. A stable fixation enables early mobilization. Intra-articular malunion should be corrected early whenever possible. And phalangeal rotational osteotomies can be done at metacarpal or phalanx level. Metacarpal level if the deformity correction needed is under 20 degree, and more than 20 degree or multiplanar deformity corrected at the original phalanx level itself. Volant anesthesia will help, and there is a learning curve involved. Thank you.
Thank you, Dr. Jayakrishnan. Lovely cases. So I'll open the forum for discussion about the cases. So I see that GK sir has mentioned in the group that how come the deformity is so well hidden when the fingers are extended, and it's only manifest when the fingers are flexed. So would you like to answer that as to how and why these
Sorry,
get
can you
missed?
repeat the question, sir? I didn't get it.
So his question is, how come the rotational deformities get missed when the fingers are in extension, but they manifest very well when the fingers are flexed?
That probably because of the joints involved, also the pliability of the joints, and that is the reason that it gets easily missed in the extension, and because of the flexibility of the joints involved, especially the MCP joints, right? MCP and PIP joints.
Exactly.
Is there any other reason?
No, if I may just elaborate, the PIP and the MCP joints are somewhat have a cam-like joint, like in the knee joint. So it's only in flexion when they get into a locked sort of a position, and that's when there is hardly any laxity, especially for the MCP joint in flexion. And when you extend it, a little bit of rotational can be compensated either the proximal level, and that's when the fingers are extended, it doesn't appear so much, and which is why we always were taught and we keep teaching that for every hand fracture, it is always better to check the flexion and rule out any rotational malunion even when you are treating it at the very first time, so that any rotational malalignment can be picked up, and these are the ones which actually qualify for some intervention, either non-operative intervention to correct the rotation, and if it is stable, then you can continue the non-operative management. If not, then you would need to go for an operative management on day one itself.
Okay.
GK sir, would you want to elaborate anything more on that, sir?
Yeah, exactly what you were saying. It has always struck me because all these patients, when you keep the fingers extended, you don't make out any deformity. Only when they flex it, you can see it totally becoming grotesque. So I was wondering. I think the explanation that you have given is quite reasonable and scientific. That you have the cam effect in the joints, which are able to sort of adjust when you extend it, but when you flex it, they get locked. So the deformity
Yeah,
becomes obvious.
manifest.
Yeah. Thank you.
Sir, you had asked about the amount of correction, right? I don't think there is an straight away an answer for that. It is usually an eyeballing. And I had asked the same question to one of my teachers, David Tan. He's very good with this kind of deformity corrections when I had cases before. And especially when you do closing wedge. When you do opening wedge osteotomy, it is easy. We correct and then we know when it is corrected, you that is enough. But when you do closing wedge, when you take out the wedge, we don't know from the beginning. And his answer was there is no easy or rule or formula. It is just a guesstimate that we know. In maybe in PG time we learned that if you take out a 1 centimeter wedge, it is 10 degree. So probably I try to extrapolate it into the finger telling. If I take a 1 millimeter, it could be that, but it doesn't. It's not always like that. So it is means we measuring the ankles pre-op and then taking a guess and later correcting it. Especially in metacarpals, we take care of the angles of the neck. 15-degree smooth curve is there in the neck of the metacarpals that we exclude and then try to do it. Most of the time, when you take the straight osteotomy, we know that how much we need to bring the bone to the correction.
Yes,
Anirban,
so yeah, so in the cases that I have done, it's like here Jay has shown, pre-op planning meticulously is very important. So we do trace it out on tracing paper, or you can do it nowadays digitally as well. And you can actually create the osteotomy, either open wedge or closing wedge. In one or two instances, I have actually had to do a dome sort of osteotomy, where if you do a sort of a dome osteotomy, you can just gradually rotate it over that dome and you can get to the desired correction. You can temporarily pin it, again check your rotations, and if you are happy with the correction, then you can go ahead and fix it with a definitive plate or screw or whatever you choose to use. And for some rotational malunions, yes, the headless compression screw technique, which Dr. Chaitanya Mudgal and Del Pinal and all have popularized, that also works because since it's an axial screw, it's easier to correct the rotation with it. But then you have to ensure again that the screw is of proper length. The inner diameter of the metacarpal matches with the screw diameter so that it locks inside and it remains stable. Otherwise, intraoperatively, if you correct the rotation and if it is loose inside, then it may lose the correction which you have done intraoperatively. So there are pros and cons of every implant which you choose. And I still find at times that plate and screw fixation with good compression. One of the things for malunions is that depending on where you are doing it, again, whether you're doing it at the neck level or the metaphyseal level or the diaphyseal level, you need to have a good compression because that will help to promote primary osteosynthesis in the osteotomy, akin to a fresh fracture. And in cases of non-union, yes, okay, we can get both atrophic type of non-union as well as hypertrophic type of non-union. So if it is a hypertrophic type of a non-union, then just providing stability is sufficient. But if it is a atrophic type of non-union, sometimes where it has been, or there is a gap non-union, then you would also need to augment it with the biology, either with a corticocancellous graft or a combination of a graft. And in rare cases, you may also need a vascularized graft depending on where you are using it.
so somebody has asked that whether how do you choose open and closing wedge. So what I do is I prefer closing wedge whenever possible because I don't need a graft and then I can get compression. This compression which you have told, and then it is easier to mobilize, whereas opening wedge most of the times needs a bone graft. But the problem is sometimes if you do a close wedge in a big deformity, angular deformity, it may cause a little shortening of the bone. So that you have to decide whether based on the size of the correction which you are planning. If the correction is bigger, then if you do an open wedge, problem is it is a slightly more unstable, I feel, than a closing wedge. So you will need a graft. You will need to wait for that to incorporate. So whenever possible, closing wedge is preferred. But like in the last case I showed, closing wedge would have caused more shortening of the bone. So I preferred for an open wedge osteotomy to bring the length back. So it causes a lengthening, whereas the closing wedge usually causes a slight shortening.
Yes. If I may just add to that, the other thing I would look at while deciding is what is the status of the soft tissues. So if there is associated, say, stiffness in the adjacent joint and it is not moving well, and if you then end up doing a open wedge, you will increase the tissue tension, so to speak, and there will be a further loss of function. There will be a little more stiffness. So for that, then you may need to do an additional tenolysis or a capsulotomy as a concurrent procedure. You have to be prepared for that. Whereas if you do a closed wedge osteotomy, you are effectively shortening it by a few millimeters, and you get a little bit of suppleness in the soft tissues as well. So it becomes easier to stretch out or mobilize if very often a malunion or a non-union will have associated stiffness in that joint. A lot of the patients don't really mobilize. We rarely come across malunions or non-unions which have absolutely supple joints adjacent to the level of.
And Katyan sir has asked whether overcorrection chance exists, sir. Surely it exists. That's why when you do a corrective and we cannot correct it and fix it in an opposite direction. So for rotational deformities, you have to be extremely careful. After you put the screws on either side, you have to check the cascade, and only once you are fully convinced, you have to put the remaining screws. Otherwise, we take out the screws and then rotate it back again. And like we know, when you do a phalanx and metacarpal plating, the over tightening of the screws is the reason that most of the time we end up with a slight rotations even in a fresh fractures. So that risk is always there. The risk is minimal with an angular deformity or a intra-articular correction, in my experience.
Can I ask one question? Supposing there has been some amount of overcorrection, is it possible to correct the problem in the post-operative period with physiotherapy?
Okay. Yes, Anirban sir. I have not experienced something like that, sir. And if it is there, I don't think it will be possible to correct it with physiotherapy. Probably surgical only will be the option. That's why means we cannot afford to do that in most of the cases.
Yes, so if it is, and again, it will depend on the type of osteotomy you're doing for the indication. So if you're doing a rotational correction and if you've overcorrected it, obviously the finger will now point the other direction, which becomes difficult. Now, in the hand, if the finger is pointing a little here, there is a little bit of overlap. So a small degree of overlap here might be cosmetically acceptable and functionally not disabling. So we can choose to ignore it. But if it's an angular deformity, say you had a fifth metacarpal shaft which is angularly deformed and the head is palpable in the palm, and you've overcorrected it, then what will happen is invariably the MCP joint then tends to go into a bit of hyperextension. And the patient will invariably come back saying that previously I could make a fist. Now my little finger sticks out a little. The rest of the fingers touch the palm, but the little finger sticks out. And you can probably compensate a little by the maybe doing a MCPJ tenotomy, but it's always better to do the correction exactly at the level and to the extent it is necessary. And so checking it intraoperatively, double checking is the most important step while doing the osteotomy.
Anirban sir, somebody has asked about the mobilization protocol. What is your protocol?
I prefer to Yeah, how early? Okay, so I usually get them to start moving the very next day itself. So most of my patients either get operated under a volant or maybe a brachial block. Brachial block I do prefer in a lot of patients because they have a post-op pain-free period, and once the pain wears off, then we can get them to start moving. In some of the cases, especially say if we've done a angular correction of the deformity, I may put a dorsal blocking splint and get them to start moving flexion, which is much easier for them to do. If it was a rotational malunion, you can always buddy tape it with the adjacent finger and again get them to start moving. So once I rarely immobilize them for long after a corrective osteotomy. At the most, maybe just a temporary splint for a couple of days. Once they are pain free, I call them back. In times, I debulk the dressing, put them onto a splint, and get them to start moving at the earliest.
Yes, like sir said, for me also, I mobilize next day. There is no role of splinting and prolonged immobilization if you're doing this. And for that, you need to be sure intra-op that your fixation is so strong that you can start moving. Whether it is an open wedge or a closed wedge, like in this last case, where even with the K wire, I just protected till the PIP and but start moving whatever area possible. And don't worry much about your graft because the fixation should be stable. That you make sure during the surgery itself. Then once you come out, there is no role of immobilization. You have to mobilize same few days or the same week itself.
Would you continue the same protocol? Would you have the same protocol if a bone graft has been used also?
Yes, sir. For bone graft, where we need bone graft is usually when you are doing an open wedge or a big shortening or a very shortened bone, you are doing a length correction. And if you are fixing it with plate and screws, you don't need, you are just stuffing it inside and you are covering all the soft tissue and it is not going to move around. And then means it is okay to start moving. If you immobilize it, then it will start adhering. We have to use more force, then problems may come. So even if it is a bone graft also it's the same. If it is a stable fixation, start moving. I normally just put bandages and I start maybe early Coban for swelling management and all, and I mobilize them.
Yeah.
Yes, so again, the bone graft which we use depends on the situation. So if there was, say, a non-union and we've used a corticocancellous graft and you fixed it with a plate and screw, so the graft is also incorporated and stable. So then mobilization is no issue whatsoever. If you've put some graft on either side as a sort of an onlay and it is loose, the maximum that will happen is some part of it will get absorbed, nothing more. Now, if you are doing an open wedge osteotomy, you have wedged that area with the graft. So after that, again, it becomes a stable construct. So then it is not unlikely to dislodge from its position.
The point that Jayakrishnan told about avoiding fixation at the level or the corrective osteotomy at the level of the diaphysis, because the shaft where the amount of bone to bone contact is less, and prefer to go to the metaphysis where you have a better bone to bone healing will be there. But are there any situations where this may not be possible? I mean, you have to do it at the shaft itself.
Yes, sir. There are a lot of situations where we
Yes,
have to do it at exactly at the shaft level because the angulation is too much at the shaft level and it is ideal to correct. So this thing about this cora or the apex is sometimes there can be only one cora, which is the, and if this cora is at the same level at the maximum deformity, then we can do a correction there. But sometimes people may have a multiplanar deformity, right? So there can be rotation, angulation, shortening. So if your maximum deformity you see is not aligning with the cora which you measured when you are doing the axis, that basically means either the patient had a shortening rotation or patient has multiple cora because of the healing. So my point was that in case it is allowing that if you do it at the diaphysis and metaphysis, it is going to give the similar result. Then to do the osteotomy in the metaphysis is easier for us because of faster healing. Because there had, when I started, there have been occasions where it took extra more than what I anticipated for me to see the healing. And sometimes it can cause an, because we do osteotomes also, right? And maybe power source, there is possibility of a non-union. Then we have a bigger problem in hand. So that is usually towards the shaft and neck, especially in phalanges. So if it's safer to start with metaphyseal level, if it is flexible and it will give the similar result. But if the deformity is too much, then you have to do it at the level of the apex itself. Anirban sir?
Yeah, so meticulous technique is important when you are doing it at the diaphyseal level. Like you rightly mentioned, we sometimes use a fine power saw. So whenever we are using the saw, it has to be constantly irrigated so that that part of the bone does not really get damaged, and then the healing is not so bad. But yes, any diaphyseal level fracture also takes longer to heal. Similarly, a diaphyseal level osteotomy also. I mean, you will have a very good stable fixation even if you have compressed it nicely, but then on subsequent x-rays you'll keep seeing that there is a faint line which remains, and that even though clinically the osteotomy site has united, patient is pain free, every time he looks at the x-ray and you look at the x-ray, both are scratching their head, why is that line still seen?
And we have to
Yeah,
explain from the beginning itself, it will heal and then the still line will be there for some more time before it
Mm.
disappears.
Yeah.
yeah, there's just one more question in the chat box. If the deformity is at the metaphyseal level of the proximal phalanx, where would you plan your osteotomy?
Sir, for if you remember, there was a thumb case in which the thumb was looking like an S shape. The injury happened intra-articular. It was at the inside the joint, intra-articular fracture, and most of the deformity was in the metaphyseal level. So you have to try to correct it there, but you'll have to adjust a implant which suits your fixation. So a thin rim plate, a T plate, which you can still have hold, has to be used, right? So if it is metaphyseal, if you still have a fragment or a piece of bone on the other side where you can do fixation on either aspects, so you have to do it in the middle of that itself, where the you see the deformity. Sometimes when you open it, we know in the bone itself where the fracture happened and where is the deformity or the yes, the fracture line is leading to.
Yes,
Yeah, in the metaphyseal region, because the bone contact is much better, it's easier to fix it. But then we are presuming that we have access to all the full set of implants, especially those T plates and mini plates which are available. So with that, life is much easier. But if you are hampered with a non-availability of those, then if you have to rely only on K wires, then it becomes more of a challenge, because at the end of it, the bottom line is after doing the osteotomy you need to fix it and get a stable fixation so that you can mobilize it immediately. If your fixation is not stable, then you will have to delay your mobilization, and then the same problems of stiffness and uh, tendon adhesion and everything happens. So the key is not just doing the osteotomy, but to fix it with a stable construct so that you can mobilize immediately.
thank you, sir. Thank you, Dr. Jayakrishnan and Dr. Anirban. That was a very interesting discussion because we rarely have time in conferences and formal meetings where you can discuss about malunions for 45 minutes. So that was the aim of this program, and it was a very interesting discussion. I'm sure we have learned a lot of points in this.